Welcome. Today my topic of discussion is hemolytic anemia. Clinical features of anemia: fatigue, paleness, yellow skin in hemolytic anemia, dark urine in hemolytic anemia, shortness of breath, dizziness, cold extremities, palpitation, angina chest pain, sore tongue, cognitive disturbance, memory loss, confusion. Physical finding: pallor, jaundice in hemolytic anemia, glossitis, tachycardia, soft systolic murmur, splenomegaly in case of hemolytic anemia, petechiae purpurae ecchymosis in aplastic anemia, diminished muscle power. In this slide, we see different stages of development of RBC from the bone marrow. In the primary stage, it is the hemocytoblast, hematopoietic stem cell. It's further going to develop erythroblast in early stage, late stage, normoblast, an exclusion of the nucleus forming the reticulocyte, and finally the erythrocyte. Before understanding of case of anemia, we have to know about the reticulocyte count. As we have seen in the previous slide, that reticulocyte is being formed from the hematopoietic stem cell, the process of early erythroblast, late erythroblast, normoblast, and finally the reticulocyte. Reticulocyte, after being formed in the bone marrow, is coming into the circulation as premature RBC. This reticulocyte is 0.5 to 2% of the total RBC count. But for actual calculation of the anemia patient and for anemia classification, it is better to depend upon the reticulocyte production index. How to calculate? Reticulocyte production index, that is RPI, is calculated as reticulocyte count of the patient into ratio of hemoglobin percent divided by 15 and 2. So, in stable state, the reticulocyte production index is 1. But when it is anemia, bone marrow is in the hyperactive stage, it is usually 2 or more. So it is better to depend upon the reticulocyte production instead of reticulocyte count. Come to the laboratory test for anemia diagnosis. First is the CBC or complete blood count. Under this heading, it is RBC profile, RBC index, RBC morphology, WBC profile, and platelet count. Under the heading of RBC profile, it is total RBC count, hemoglobin, hematocrit, reticulocyte count. Under the heading of RBC index, it is the mean corpuscular volume, mean corpuscular hemoglobin, mean corpuscular hemoglobin concentration, red cell distribution with RBC morphology, WBC profile. Under the heading, it is WBC count and WBC differential count and platelet count. Next, come to the body iron profile. Under this heading, it is the serum ferritin, serum iron, and total iron binding capacity. Next is the serum vitamin B12 and folic acid estimation. Marrow examination, it is marrow aspirate and marrow biopsy. Some salient points regarding the anemia diagnosis. As per WHO, when the hemoglobin percentage is less than 13 gram per deciliter in male and 12 gram in female, it is anemia. When hemoglobin percentage is less than 8 in male and less than 7 gram per dl in female, it is severe anemia. Mean corpuscular volume determines the RBC cell size. When it is more than 100 femtoliter, it is macrocytic RBC, but when it is less than 80, it is microcytic RBC. Mean corpuscular hemoglobin and mean corpuscular hemoglobin concentration determines the hypochromic RBC. Red cell distribution width determines the variation in the RBC size and it should be less than 14.5%. Now come to the anemia classification. As I have discussed in the earlier slide, we have to depend upon the reticulocyte production index for anemia classification. RPI less than 2, RPI more than 2 or 2. First, we will discuss the RPI less than 2. Normally in anemia, the RPI should be 2 or more as per normal marrow response to the anemia. But when it is less than 2, we can say the marrow is non-hyperproliferative. It is non-hyperproliferative marrow response. Under this setting, it is the deficiency of the nutrient, that is iron deficiency, cobalamin deficiency and folic acid deficiency. Number 2 is the erythropoietin insufficiency, as in chronic kidney disease, chronic inflammation, cancer, etc. Number 3 it is the marrow insufficiency, as is myelofibrosis, aplastic anemia, myelofibrosis, like this. What is the RBC pattern? In the iron deficiency, it is normocytic normochromic anemia RBC in the early iron deficiency, but in the advanced iron deficiency, it is microcytic hypochromic RBC. In cobalamin and folate deficiency, it is the macrocytic RBC. Now come to the erythropoietin insufficiency, it is the normocytic normochromic RBC. In marrow insufficiency, it is normocytic normochromic RBC. Now come to the RPI 2 or more. This is the hyperproliferative marrow response. Under this setting, two important items, chronic hemorrhage and hemolysis. What is the RBC pattern? Chronic hemorrhage, it is microcytic hypochromic RBC. It is like the picture of severe iron deficiency pattern. Under the hemolysis, there are so many items under hemolysis like hemoglobinopathy. Under the hemoglobinopathy, it is thalassemia, sickle cell anemia. Similarly, it is enzymopathy like G6PD deficiency, membranopathy like hereditary spherocytosis, electrocytosis, paroxysmal nocturnal hemoglobinuria, hemolytic uremic syndrome, microangiopathic hemolytic anemia, autoimmune hemolytic anemia, toxin, and so on. And what is the RBC pattern? Usually it is normocytic normochromic, but in case of thalassemia, it is hypochromic microcytic RBC. So, if we see a picture of hypochromic microcytic RBC, we have to think three things. Maybe case of severe iron deficiency, it may be case of chronic hemorrhage, it may be case of thalassemia. So we have to depend upon the ferritin, serum ferritin level for detection of the severe iron deficiency or chronic hemorrhage, and for thalassemia or confirmation is to be done by hemoglobin electrophoresis. The distribution of anemia. Iron deficiency anemia, commonest, 50 to 60% of the total. Next common is the chronic disease including CKD and inflammatory anemia, 25 to 30%. Vitamin B12 and folic acid deficiency anemia, 5 to 10%. Hemolytic anemia, 1 to 3%. Marrow failure anemia, 1 to 2%. Hemolytic anemia classification. Hemoglobinopathy, under this heading it is thalassemia, sickle cell anemia. Enzymopathies like G6PD deficiency. Membranopathies like hereditary spherocytosis, electrocytosis, so on, and others, as for example paroxysmal nocturnal hemoglobinuria, hemolytic uremic syndrome, microangiopathic hemolytic anemia, autoimmune hemolytic anemia, toxin infection like malaria. What are the features of hemolytic anemia? Splenomegaly with a hypersplenism effect like neutropenia, thrombocytopenia, sometimes hepatomegaly, jaundice, usually unconjugated hyperbilirubinemia, in this case, pigment gallstone, LDH is high, haptoglobulin is reduced to absent, MCV usually increased, normocytic to mild macrocytic RBC, anisocytosis, poikilocytosis, polychromasia, and reticulocytosis, and few specific cells for specific type of hemolytic anemia. Let us discuss about the normal hemoglobin structure. What you see in the normal hemoglobin, there is tetramer of amino acid chain, two alpha globin chain and two beta globin chain forming the hemoglobin A. Two alpha globin chain and two delta globin chain forming hemoglobin A2, and two alpha globin chain and two gamma globin chain forming hemoglobin F. Normal hemoglobin distribution according to percentage: hemoglobin A 95 to 98%, hemoglobin A2 2 to 3.5%, hemoglobin F less than 1%. Hemoglobin F level tend to rise in thalassemia and sickle cell anemia due to deficient or defective globin chain synthesis in hemoglobin A formation. In hemoglobinopathy, it is in the thalassemia beta, there is decreased beta chain synthesis, whereas in the sickle cell anemia HbS, this defective beta chain synthesis. Sickle cell patients are protected from lethal effects of falciparum malaria due to insufficient space for the malarial trophozoite development in a sickled RBC, as well as early recognition and destruction of the RBC by the spleen, causing rapid parasite clearance. Let us discuss about the beta thalassemia measure. What happened? What are the salient points? Reduced supply of globin chain synthesis resulting into diminished production of hemoglobin tetramer. As a result, hypochromic and microcytic RBC formation. Lack of beta chain causing highly insoluble unpaired alpha chain which form toxic inclusion bodies. This is the burden of RBC detected by the spleen, resulting into RBC destruction and severe hemolytic anemia. Extra burden falls over the marrow, causing marrow hyperplasia, maxillary prominence, frontal washing, forming chipmunk faces. Extramedullary hematopoiesis also occur in the liver and spleen, causing hepatosplenomegaly. Features of hemolytic anemia as hepatosplenomegaly, leg ulcer, pigment gallstone, jaundice, chronic blood transfusion in beta thalassemia major cause iron overload which is fatal by the age of 30 years. Hemoglobin electrophoresis shows increased fetal hemoglobin and hemoglobin A2. Peripheral smears showing microcytic hypochromic RBC which mimics severe iron deficiency picture with target cell, teardrop shaped cell, anisocytosis, poikilocytosis and increased reticulocytes. Regarding beta thalassemia minor, it is mild anemia, but peripheral blood picture mimics iron deficiency anemia. It has to be differentiated. Let's see some pictures of beta thalassemia major. In this slide, see variable sizes RBC, variable separate RBC, anisocytosis, poikilocytosis, bullseye appearance or target cell, RBC with dark center, teardrop shaped cells, increased reticulocytes in the peripheral picture, typical pictures of hemolytic anemia, splenomegaly, characteristic of hemolytic anemia, frontal bossing with zygomatic and maxillary prominence forming chipmunk faces. Now I discuss about the sickle cell anemia. What happened? It's defective beta globin chain synthesis due to replacement of amino acid glutamic acid by the valine in sixth position. As a result, the anemia develops. This anemia is very severe, hemoglobin 7 to 8 gram per deciliter. Confirmed by electrophoresis, which detect the hemoglobin S. When hemoglobin is deoxygenated in venular capillary, this hemoglobin S polymerases reversibly to form a gelatinous network that stiffens RBC to produce stiff, sticky, and viscous, which is difficult to pass through the venular capillaries. As a result, tissue and organ ischemia with microinfarction. This is the fundamental basis of painful crisis and priapism. Provocating factor for the painful crisis are excessive exercise, fever, dehydration, emotional change, abrupt changes in temperature, and hypoxic state. Organs affected: spleen. Autosplenectomy usually occurs by fifth year due to repeated microinfarction, liver, kidneys, lungs. In lungs, acute chest syndrome causing tachypnea, fever, cough mimics pneumonia. In bones, joints, retina, and also the central nervous system. Features of hemolytic anemia as hepatosplenomegaly, leg ulcer, pigment gallstone, unconjugated hyperbilirubinemia causing jaundice. Most painful crises resolve within 1 to 7 days and can be managed with vigorous oral hydration and analgesia. Antibiotic prophylaxis in minor operative procedure as the splenic function is lost in the early age. Pneumococcal vaccination before autosplenectomy because spleen is one of the site for B cells antigen recognition which subsequently produce antibody after subsequent antigen challenges. Hydroxyurea 10 to 30 milligram per kg per day is useful to increase the fetal hemoglobin. This is the mainstay of therapy. In this slide, we see the sickled RBC. Here, the arrow showing the sickled RBC in both left and right sided picture. These are the sickle cell. This sickling occurs in deoxygenated condition, particularly in the venular capillaries. G6PD deficiency, it is X-linked transmission. Vast majority of the patients are clinically asymptomatic throughout their lifetime, but all are in increased risk of acute hemolytic anemia when challenged to oxidative agents. Triggers for hemolysis: drugs like primaquine, dapsone, sulfamethoxazole, nitrofurantoin, and infections. Hemolytic attack starts with malaise, weakness, abdominal pain. Acute renal failure is the most serious threat of acute hemolytic anemia. RBC pattern are same as typical hemolytic anemia. However, semi-ghost cells, white cell, blister cells are typical. Aim is to avoid exposure of triggering factors. This is the example of white cell. Hereditary spherocytosis, 1 in 5,000 population. RBC are usually sensitive to hypotonic solution resulting into lysis. This is the basis of osmotic fragility test. Here we see the spirocyte cells, treatment splenectomy. Paroxysmal nocturnal hemoglobinuria. The pathology is RBC lack CD55 and CD59 protective protein, which makes it sensitive to complement mediated distraction. Triad of pancytopenia, venous thrombosis, and hemolysis. Most patients are young adult, passing blood in early morning instead of urine. Without treatment, median survival is 8 to 10 years. Flow cytometry is the gold standard for diagnosis. Treated with transfusion, iron, folate supplementation, eculizumab. Transfusional hemosiderosis. 1 unit of packed RBC contains 250 to 300 mg iron, equivalent to nearly 1 year oral intake of elemental iron, considering daily elemental iron is around 1 milligram. Patients who receive more than 100 units of packed RBC usually develop hemosiderosis with rise of serum ferritin level as iron has no mechanism of excretion. Pathology, endocrine dysfunction causing delayed puberty, glucose intolerance, cirrhosis liver, cardiomyopathy. Treatment or prevention, deferoxamine parenteral or oral deferasilox 20 to 30 mg per kg per day is useful. Thank you to all.